Okay.
So,
So, uh, my talk, I think, supposed to be on medications and lifestyle. That would be an hour and a half talk. So I will be focusing my talk only on medications this evening. If you come to the conference, I will be giving an hour plus talk on medications and lifestyle. But for this evening, I'm going to limit it to just medications. I do have a series of slides. Don't be too overwhelmed. I'm going to do a little bit of just explaining what we mean by ADHD and then move into medications. So there will not be a test after this, so don't worry. If you forget, it's perfectly fine. And so we'll get started here. So
yeah.
adult ADHD medication management. Next slide. Okay, so
You can probably just leave it on like this.
okay, so the question is, why treat? Why should we even bother? Well, to understand what we're dealing with, next slide, ADHD is highly prevalent. It is between the ages of 5 and 17, children and teenagers, we see anywhere from 9 to 15% prevalence, so approximately 7 million in the United States. And then ages from 18 to 44, about 4.4%, which totals about 10 million people, the population of adults. Now, why do we see this range, children and adolescents, is because depends on the region of the country that you're in, the community that you're in, it depends on race, Hispanic, Asian, Caucasian. So there are a lot of factors as to that, the range there. In adults, you see 18 to 44. Why is it cut off at 44? Because we really don't have studies looking beyond that age, to middle-aged and later years. We're beginning to study that more, but that's still ongoing, and we're at the beginning phases of that. A lot of people who are older do not get screened, even if they go to see their doctors and complain of memory issues and emotional lability or dysregulation. The providers don't pull out an ADHD checklist or screening to screen them. So they're often not screened. So the next slide shows when we're talking about ADHD, we can move on to the next slide.
Oops, sorry.
So impairments associated with adult ADHD, and there are quite a number of them, and it starts with, like, at the bottom there, limited educational success. So fewer adults with ADHD do end up actually graduating from college or going on to graduate school and other professional schools. We have greater family conflict and stress. Fewer adults with ADHD do get married, and more adults with ADHD actually get divorced than the average. Neurotypical. Peer relationship problems, I hear about that, especially in the work environment. That could be an issue. Antisocial behavioral, legal problems. We see a lot of ADHD adults end up in the criminal justice system. There's more substance use, smoking, marijuana, alcohol, risky sexual behavior, early pregnancy. Studies show that in especially young adults. Accidents, injuries, and suicide. The injury rates are higher in adults with ADHD, and you see that especially like in children and young adults. They have a shorter lifespan than those without, and a lot of the times it's due to those factors. Driving risks, we know there have been plenty of studies by Russell Barkley looking at the risks associated with driving in people with ADHD who are unmedicated, occupational, financial, poor health across the board. Adults with ADHD tend to have shorter lifespans, by about 13 years than people without. Poor health outcomes, obesity is associated with ADHD, marital cohabiting issues, and as I mentioned, higher divorce rate among people with ADHD, impaired issues with parenting. It's very heritable, so often the parent has it, some of their children will have it as well. So there's a lot of issues associated with having adult ADHD that we need to be aware of, and therefore really make an effort to diagnose and help manage. Next slide. Okay. There's a cost to society because of all these issues. Study looking at 12-18, over $122 billion unemployment money there, 66.8 billion, productivity loss, healthcare services. So you're looking at billions and billions of dollars loss in our economy due to issues facing adults with ADHD. Next slide. So the medications, can they be helpful? Next slide. Can we improve things? So we find, there are plenty of studies that looked at medications and how effective, they can be highly effective, especially compared to other medications for other conditions, mental health conditions. We have a really good response rate. Many studies show that, and we're looking at upwards to 80% response rate. They tend to be pretty safe. No one dies from ADHD meds when taken as prescribed. Few side effects, and we'll go over those. They're actually manageable. No known long-term side effects to date from the studies. And lastly, is there a neuroprotective effect? And studies are showing, yes, there are neuroprotective effects from taking these medications. So good reasons to look at meds as a way to help with the symptoms of ADHD. Next slide. And just to show that, the next slide shows a meta-analysis of, a meta-analysis means looking at many studies of subjects and comparing what their response is to the different groups of medications. So we have like the dextroamphetamine, the amphetamine group, best response of 36%. The next group, methylphenidate, 26%, and both together, equal response to either stimulus, 38%. So if we look at that, those are quite high numbers, especially compared, again, to other medications that are used for other mental health conditions. Next slide. So just a neuroprotection, I'm going to throw that out there. Something that's being talked about in the research literature, but not so much in, the media. If you look at, Wall Street or the New York Times or Washington Post, they're not going to be exactly talking about this. We tend to hear more about the negative aspects of these medications, but they're actually neuroprotection that is being looked at. The review of 29 studies, therapeutic oral doses of stimulants, decreased alterations in brain structure. So we have a lot of PET scans and functional MRIs, a lot of imaging studies that look at this and compare the brains, for example, in children, of those with and without ADHD and on medications. We find their studies are showing that there are actually improvements anatomically in the brain structure in kids who are medicated versus those who are not. Adults with ADHD, more recently, some findings of enhanced development in the frontal lobe gray matter as a function of duration of the stimulant treatment has been noted. And that study was from 2012, so a while ago, and more are coming out, comparing the brains of those of ADHD adults and those without ADHD, and then those adults who are treated versus not treated, and actually finding differences. Okay, next slide. So what are some of the side effects? So you can have some decreased appetite, nausea, abdominal pain. Now in my adult patients, I do not manage young adults, or I'm sorry, children or adolescents. So decreased appetite in the adult population, I don't worry so much about compared to probably somebody treating a child. Actually, a lot of my patients don't mind losing a few pounds, but I do stress that they need to eat throughout the day. It's very important. Brain needs energy. We talk about that, but less important in my adult population. There could be some nausea and abdominal pain that tends to go away after several days. Usually dry mouth, that could become more of an issue in older patients with ADHD. So not so much in my younger population, but probably 50 and older, you start having, I have to be cognizant that there could be complaints of dry mouth, for example. And headache, again, headache tends to resolve. Insomnia, however, that's a very common problem in ADHD. So just have, I'm always screening to find out if the insomnia has worsened than usual. There could be increased heart rate and blood pressure, palpitations. So I monitor for that. I ask about blood pressure. But studies show that the elevation in blood pressure due to stimulants is actually very little. It could go up by a few millimeters, but it is not something that's pronounced. Obviously, having adults with ADHD, a number will have hypertension, high blood pressure, and I just make sure that they're being treated for that, as they are medicated, as they're put on the stimulants, and that doesn't tend to be an issue. Rare side effects, tics. Meds are thought to unmask rather than cause tics. If somebody does have tics, it could worsen tics. So I do ask about that. Psychiatric risk, there could be psychosis, mania, and suicidal ideation, but that's if people are really, that can happen mostly if people are on higher doses of stimulants and perhaps higher than they should be. And that could create an issue. So you have to ask, I have to ask for that and practice within certain guidelines to ensure that is not likely to happen. There's a question whether there's a lower seizure threshold taking these medications. Of all the patients that I've had on stimulants, which is my first line of management, to date, no one has had a seizure from being on stimulants. There is concern about misuse, abuse, and diversion, and there are a lot of studies showing that college students are infamous for this, up to 35%. They're taking people's, passing them around, and that can become an issue. So we have to be very careful about that, and state registries monitor use. So every state has a registry where you can see what people have picked up from the pharmacy as a way. There could be urine testing. So in adults with ADHD, it's important to monitor heart rate, blood pressure, height, not so much, more in children, weight, again, more in kids, signs of diversion in the young adult population, primarily. Next. Okay.
I just have to say, I'm still figuring this out, so I
Okay.
apologize for the funkiness of it all. Slide navigator, there we
Here we
go.
go. Yeah, perfect. So what do these medications do? So in order to understand that, how they work, we need to know, well, what's going on and what are we trying to do here? The basic issue, next slide, is a biochemical one, and we're talking about neuromodulators within the brain. So ADHD is fundamentally a chemical problem. The most effective treatment is to change the chemistry, and we can do that with medication. Not only with medication, there's a direct impact, certainly with medication. Dr. Mary Rawson will talk about, how can we change the way we manage ourselves through a more of a psychological perspective than with medications. Obviously. So unless the problematic chemistry is changed, other interventions are not like to be as effective of medications. However, they can still, they play a role. So I don't want to suggest that medications are the only way to manage symptoms. A lot of people can't tolerate medications. And some people would rather try other means to manage their symptoms. So they work hand in hand. Next. So the two chemicals, the neuromodulators, we call them neuromodulators, are dopamine, norepinephrine. They control most of the functions that we consider impaired in ADHD. Brains do make these chemicals. Our ADHD brains do make them as other brains make them. But there is an issue with the release of these chemicals and the reload effectively, and the reload. So the messages are not connecting in the way that they should be at the rate that they should be. For 80% of those with ADHD medication can help and can improve this problem. By improve, I don't suggest that completely take care of the problem, and that's why other means are important, other domains are important too, as well as medication. Next. So here we have an example of what we call, these are neurons. The brain has about 100 billion neurons. Most of the neurons are in the cerebellum and not in the prefrontal cortex. And with 100 billion neurons, each one of these neurons can affect, thousands of others at any given point in time. So we're talking about 100 trillion synaptic connections that could possibly, that could take place at any given moment, which are quite a number. So how do these work? You have the presynaptic neuron, you have another neuron, and you have chemicals that stimulate the next neuron, and then an electrical impulse is given off. And so we have here, we call them catecholamine neurons because they produce dopamine and norepinephrine primarily. And what the medications do, here we have amphetamine will block the reuptake of dopamine and norepinephrine. Amphetamine increases the neurotransmitter release into the synapse. And then we see here the amphetamines and methylphenidate block reuptake of dopamine and norepinephrine, and atomoxetine and viloxazine block the norepinephrine transport. So these are non-stimulants, but this is how they work. So this is just to give you an idea of the communication that takes place between one neuron and the next, and what happens in the presynaptic space there, and how these meds directly impact the regulation of these catecholamines in the neurons. So this is why the medication, this is how they impact the brain, and why now we have more of these neurochemicals around. Next. So we have networks in the brain. We have 7 main networks in the brain. And so these neurons connect with one another, and they connect different parts of our brain. So from our prefrontal cortex to the limbic system, where we have the amygdala, to the cerebellum, the lower part of the brain. So the regions of the brain communicate with each other through networks. So we're dealing with the biochemicals, but also with networks. And we have here, through PET scans, imaging studies showing the various areas of the brain that are involved in, for example, what we call the default mode network, the anterior salience network, and the central executive network. So we have many different networks, and within those networks, we have other networks too. And so the default mode network, for example, you see the guy that's sitting there at the computer, is kind of the network that kind of takes over when we are daydreaming or being more introspective, and we're kind of, he's like thinking about vacation, where he should go. Then we have the anterior salience network that is more task driven, like I need to get these tasks done to do, reach my goals. Then we have the central executive network that is all about scheduling, planning, organizing, etc., to get to make these goals happen. So there are a number of them, and these networks work together in synchrony. The prefrontal cortex is like the conductor of a huge symphony, and we'll tell one part of, the symphony is made up of different sections of instruments, and you have like the percussion section, you have the violins, another section, you've got the wind instruments, and etc. So the conductor is kind of telling one section to kind of play less loudly, and another one, maybe the percussions, to play more loudly. And so you have gradations of sound so that the final sound sounds beautiful. So it's not like a switch suddenly turns on and off. And that's why they're called neuromodulators, dopamine, norepinephrine, because they modulate, they can temper, they can increase or decrease, enhance or not enhance the various neurons to then activate and go down these pathways. So next slide. So medications. So which medications, what are the different choices? Next slide. And that could be an issue because there are many. And I just threw this up here. This is an example of starting from 1937, a Benzedrine. It was a racemic amphetamine, 1943. Another variation where it's called digoxin or methamphetamine, actually. And then 1955, Ritalin, 1955. So you can go down this list and see how the different medications have evolved over the years. And up until 2023, we have Zelstra, which is the first once daily transdermal amphetamine patch. So a number of choices with a number of dosages approved by the FDA. Next. So if we look at medications worldwide, we have the stimulants up there, and we have two main groups, the methylphenidate group and the amphetamine group. And they come in different formulations of short-acting, intermediate, and long-acting, different dosages, oral, transdermal, capsules, tablets. And then we go down the list here and we have the non-stimulants, which are approved, and the ones not yet approved. The ones that are approved are Strattera or atomoxetine and Quilbray, which Strattera just went generic, and Quilbray is a new one. It is branded Viloxazone is the other name for that one. And then we have Intuniv, guanfacine, and Capve, which is clonidine. And we have some investigational drugs going on currently as well. Next. So here is a chart of the amphetamine formulations, the long-acting, and also oral formulations of the long-acting. We have the prodrug formulations of Vyvanse, and that just means the active chemical is connected to a amino acid lysine. So it's a different form of delivery. Then we have the short-acting oral tablets there, and then the non-stimulants. And here we see Intuniv, and Capve, Strattera, and Quilbray. Next. Then if we look at the methylphenidate group, we have the long-acting and then also oral. We have the patches there. Then we have the prodrug formulation, as a Steris, which is relatively new. Then that's a prodrug like Vyvanse in the amphetamine group, methylphenidate, long-acting, delayed onset, Jornay. You take that in the evening and then it kicks in by the morning. And then we have the short-acting oral. So these are just example, I mean, just to inform you of all the different choices that we have, you know, in this class of drugs. Next, medications. So which medications have actually been approved by the FDA for adults? Not very many. So we see here atomoxetine or Strattera, adult dosing up to 40 mg, max 100. The studies, however, have gone up to 120, where they've gotten a response from the people being studied. And then we have the dexmethylphenidate extended release, also called Focalin. And we see here the adult dosing range 10 to 20 max. However, in the trials, they've looked at a positive effective response at higher doses of 40. And then the triple bead mixed amphetamine salts, such as Mydayis is the brand name. In kids, no indication. And then we see here moving to adults, max 50, and then we see the US trials at 75, so they're higher. Then the mixed amphetamine salts, XR, such as Adderall, brand name. Here in adult dosing, it says 20, max none. So we're seeing it being prescribed, you know, at higher doses than what the FDA has approved for the adult dosing. And we see here up to 60 in the clinical trials. And the methylphenidate, HCl, such as Concerta, we see in the adult population max 72, but up to 108 milligrams in the trials. So this shows that we as prescribers have a, you know, we do go up over the FDA range at times, not always, but there are times when we need to in order to get the most effective dose. And that, you know, how do we decide that? It's not really decided on weight or age. And really what the important thing is how somebody metabolizes, breaks down these medications. And that's really dependent on how much enzyme they have around to break these medications down and metabolize them. And that's not an easy thing to know. There's no gold standard or genetic testing that I could order to let me know exactly, you know, how this person will be metabolizing these medications. So it takes an astute provider to understand, you know, how does this person metabolize these medications and then prescribe accordingly. So I can have a very thin patient who I believe is not diverting medication or misusing them, but requiring, you know, over 100 milligrams a day of amphetamine. I can get an obese patient who might just need, you know, 5 milligrams or 10 milligrams and actually microdosing. It also depends on the symptomology. So there are a number of symptoms associated with ADHD and also, you know, how significantly impacted people are because of them. So there are a lot of variables. Next slide. There are advantages to prescribing extended release formulations. Now, they provide a sustained medication level throughout the day. You tend not to feel the ups and downs. It's more smoother. There's no midday dose requirement, which a lot of people can forget that second dose. therefore enhances patient compliance, once a day dosing. It can reduce illicit diversion and abuse as well. Harder to abuse a long-acting formulation than a short-acting. However, they can be more expensive. So if you don't have health insurance, that can be an issue. But ideally, we like to manage patients on a long-acting formulation if we can. That would be best. Next slide. Now, are there guidelines? Well, as you see here with adults, the only US guideline is from the American Academy of Family Practice Docs. So we have to extrapolate from guidelines and best practices for adolescents and, kind of plan for the pharmacotherapy accordingly. So there are no clinical guidelines yet, which is surprising. We go by, guidelines, best practices. So we are still waiting for the American Academy of ADHD and Related Disorders has a panel working on clinical guidelines so that prescribers of adults with ADHD can be more in line with how they prescribe. So there's an issue around that and it's being worked on currently. So we can have more standard of care. Next. So what are some considerations when we're dealing with medications? Next slide. People ask me, will my personality change? Will I become a zombie? Slow growth, that's not so much with in the adult population. Will tics start? Will I lose my appetite? What about sleep? Will I develop an alcohol problem or a drug problem later? Will I be dependent on these meds for lifetime? There are issues around being labeled, attribution problems, and then reactions of family, friends, and peers. So these are some concerns. I hear in the adult population, will I become dependent on these meds? Do I have to take these meds for my whole life? And actually with the people that I see, they're very concerned about these meds. So I think there's a lot of misinformation out there and judgment about these meds and how, that everybody with ADHD wants to be on these meds. And that's really not true. People who come to me are concerned. They want to know the latest research, what are the long-term side effects of these medications? They're very conscientious. So that's why it's important for providers to be well-informed and give them the information based on, good studies that are being done. Next slide. And here's a study that just came out in April of 2024, so just very recently, the impact of treatment with central nervous system stimulant and the risk of substance use disorder in adults with ADHD. And basically, they found that of 28,540 ADHD patients who were mostly white between the ages of 18 and 44, the central nervous system stimulant users were less likely to develop a substance use disorder and took longer days to develop a substance use disorder and utilized fewer inpatient emergency room services. So their findings emphasize the need for assessment and treatment of adults with ADHD to mitigate the risk of actually developing a substance use disorder. So actually being on these medications, and this is a huge study, confirming that no, you're not going to become a drug addict or a substance use. You're not going to develop substance use disorder being on these medications. Next slide, please. So here in taking these medications, there are phases. There's an active phase, a drop off, and you want to ensure that during the active phase of medication, the effects of these medications, that you're not feeling irritable, or you kind of don't feel wired or racy. I mean, it's important that the provider knows what's going on during the active phase of this medication, because by knowing how you are responding, then the dose can be adjusted of the medication. There's also potentially a drop-off. If these effects occur as the med is wearing off, you can have rebound effects. So you could become very irritable. There's a lot of fatigue. So the symptoms that you had previously, just worsen in a drop-off phase. And so, I have to ask about that too, not only during the active phase, but the drop-off phase. How is a patient responding as their system is metabolizing these medications? Next. So the way patients can help prescribers fine-tune is let them know about the significant problems, what they are, when they are, how long they continue, especially during the phases that we just looked at. Report apparent benefits too. And then don't assume that all the changes, good or bad, are due to medication. There are other factors. Sleep is a huge factor. Are they, how are they using other stimulants, caffeine, nicotine? How are the stresses in their life? Are they under undue stress? So it's really important to, when you're looking at medications, looking at the whole person and what is going on. Are they going through menopause? Are they, and women who are menstruating will have issues around during the follicular phase of their menses too. Next. Big question I get, are ADHD medications safe in pregnancy? Next slide. And so women are being diagnosed as adults. We're seeing a one-to-one women and men with diagnosis of ADHD. So therefore, a lot of my patients do plan on becoming pregnant and breastfeeding. And that's not like 50%. And that's not a population that we can ignore, that I can ignore, that anybody should ignore. Women, we need to have way more studies looking at the impact of these medications in women who are pregnant and breastfeeding and who have ADHD. So here's a study, website of a study going on at Massachusetts General Hospital, where people can enroll if they are pregnant and they follow patients who are pregnant and taking stimulants. Ethically, they can't do any studies and put people on medications and not. So what they can do is follow longitudinally these patients and retrospectively. And so that's what currently is being done more as it should be. It's been an area that's been very neglected and not looked at all, because even the diagnosis and management of ADHD in adults is relatively new in the last 20 years or so. And now slowly they're beginning to look at women and pregnancy, but it's just an emerging field of research currently. Next. So ADHD is a complex, multifaceted neurodevelopmental condition with strong biological basis, beginning in childhood, persisting through the lifespan. We used to think that it didn't persist in adulthood, and now we're looking, the literature shows that 70 to 80% of kids will go on to showing signs and symptoms of ADHD later in life. So it definitely is across the lifespan. Effective medications impact multiple brain regions, controlling attention, inhibitory control, default mode processing, reward and motivation, emotional regulation. And the medications in general are safe with high response rate and with manageable side effects when taken as prescribed. So thank you for your attention. I know this is like really long, and no, you will not be tested. So it was just kind of to get a taste of what this is all about. So thank you.
That was great. Thank you, Dr. Heithaus.
Thank you.
Let's see. Let me stop my share. And we've got questions. Several questions were emailed in, and I was just in the process of typing up all of them to Mary Rawson to help sort them. I think one question that that was asked in chat, and I think you've already covered, but I wanted to see if there was more Q&A wanted on this with either the asker or if other people wanted to dig in deeper. And that is the risk of addiction. I'm sorry, the risk of addiction with stimulants.
Yeah, so as I showed, there was a recent study in April of 2024 looking at, well, I guess substance use disorder. Risk of addiction, I believe what they're asking is if you take just stimulants, can you become addicted to them? I have not seen that clinically in my practice. That can happen if these meds are is how they're being prescribed, and whether a patient keeps asking for more, and if the clinician is not properly noting side effects, benefits, etc. And but to be honest with you, of all my patients, I'm not getting requests to keep hiring doses and asking for more med. I mean, that's not a typical scenario. If there's an issue about that, I would really investigate and find out, is this really, is this somebody who is having, has a very fast metabolism, a lot of enzymes around, and is going through these meds pretty quickly. So I want to give the patient the benefit of the doubt, certainly. But that is something to keep in the back of my mind too.
I think, I mean, because I was one of your patients who was really, really afraid of mental health meds in general and just stimulants. My mom was a nurse in the 70s in, working in the psych ward. So I'd heard all these horror stories. And I appreciated how you asked all these questions, and yet I would still bring these questions to you. I think the thing that I've learned over time is that the more I take, the worse I feel.
Mhm.
Right? It was never something that the more I took, the better I felt. Okay, we've got another on this. Okay, what meds are good for people who have a comorbidity? Sorry, hard for me to get my mouth around that, of depression and ADHD.
Yeah, so what meds are appropriate? Well, actually, the stimulants have an added benefit of a feeling, I call it a well-being, a feeling of well-being. I'm not calling this euphoria or like you're on speed or anything like that. That's a bad sign. But just a general feeling of optimism and well-being on these meds. That's an added benefit. So if somebody comes to me with depression, anxiety, or depression and ADHD, I have to look at each cluster of symptoms separately and how much one is affecting the other. Because obviously when you have depression, your cognition could be impacted. And, so if I'm dealing with, if there's both, I tend to look at the ADHD first, as long as the depression is not severe. And if it's a mild depression, I tend to kind of steer towards the ADHD first and managing that. And often the stimulants may be enough. If the stimulants are not enough, then we kind of move forward. If the depression is still there, then that's where we can, we might be looking at 2 different medications, but that's not the usual case. Usual case that people can tend to feel better on the medications, and it also is due to, why are they depressed? The reasons why there can be this depression to begin with. So you have to really understand what is going on there too with the depression. How long has it been there? How severe it is? Is it situational? Is it ongoing?
Awesome. Thank you. Okay, so whoops, I didn't mean to thumbs up that one. That was my own comment.
I see one question here, which is probably a question a lot of people would want Angela to answer about a need for brand versus generic, especially with the shortages of pharmacies and pharmacy benefits members dictating mid-year changes and formularies. So please address this specific brand versus generic. What's your feeling about that?
Yeah. I
Okay.
think that was from Eric in Florida. Erica, did I capture that correctly?
Yeah, you and your team there, Mary, who just read that, was that you? Thank you. Yes, that's what I sent in, and that comes up with. Been going to CHADD meetings a long time myself. That comes up. People go crazy with that. Something is unavailable, and they're saying, "Oh, just take this other one instead." And it doesn't work. And I just wondered if you guys intervene, although that's not your primary role.
Yeah, so the answer to that is that's a huge problem. And it really depends on what type of insurance somebody has, what their plan is. There are a million options, a million insurances. I can't keep track. I would like to, there are a certain number of brand medications that I would prefer to prescribe, but I ask patients first, like, what insurance, do you have insurance? Is it relatively a good insurance? And then a lot of these insurance companies will not approve brand unless they've trialed a bunch of generics. And so then we do step therapy on generic medications. And that's a whole other topic. But then Vyvanse, for example, has been on the market for about 20 years. It just came out generic about a year ago, and pharmacies started having no supply of the generic, but supply of the brand. And so insurance companies were like, well, you have to pay for the brand. And so I instruct patients to call their insurance company and say that their pharmacy does not have the supply of the generic and they have to have brand. Now, some insurance companies will override that and say, fine. So I encourage patients to be advocates and go back to the insurance company and advocate for brand when there's no generic, because that's been a huge problem.
Yeah. Eric, it's funny that you asked that because I've been working with Dr. Heithaus's office over the last couple of months on this very situation. And it isn't just the insurance company, it's the plan within the insurance company. So I was on the open market and I was being covered on Vyvanse. I was, and that went well until March 1st. And then in March 1st, they're like, that is not part of your formulary. And I'm like, it was before. They changed my formulary mid-year, right? So then when I got on the phone, I specifically wanted to go through this horrific process. It took me a lot of time. It took Angela's office manager a ton of time to deal with this. But they said, here's a secret form called a formulary exemption, not a prior authorization. It's these magic words. And Deb took care of this, got it done, got it submitted. and my insurance company, my plan accepted it. Then the next month I had a new plan with a group, better plan, and they're like, we don't recognize this formulary exemption. You have to do it again. And it took another 2 or 3 days of talking through the very same insurance company that had access to both plans before they finally said, yes, it's okay. And in the meantime, Deb had already sent in she already went through the work, right? So it is a roulette table every time. And all I can say is that if you get that benefit from the brand, work with your doctor's office and pin down the insurance company like a butterfly. Like you gotta track it.
So the only thing I heard about was from time to time, if the doctor, Dr. Highsmith, whomever it is, writes, please fill as written versus without substitute or something. If the prescription can be
well, yeah, that's
direct,
called
something
DAW.
like-
Yeah, it's DAW, dispense as written. And there is a dispense as written #1, and there's a dispense as written #2.
Yeah.
#1 means the doctor says dispense as written, which requires a prior authorization. Dispense as written 2 means the patient's requesting it. Which means the patient can talk to the insurance company directly and kind of ask for an override. If any of that made sense.
ends up being the hardest part of your job. Thanks for the question today.
Yeah. Okay. Mary Rawson, what do you think for the next one?
Oh, how long will it take me to get over my ADHD diagnosis? It's kind of like I was thinking about that question. That question could be a lot of things. Unfortunately, it looks like the person emailed it. Like, it doesn't mean how long.
She's in the meeting.
Oh, good. So I'd love to hear from that person. Does that mean how long to accept your ADHD, or how long until I no longer have to deal with ADD being a problem in my life?
I think just when will it be resolved? Like, how long does it take to get to the acceptance stage?
Well, I appreciate that. Yeah, I think that it is a lot faster if you do education, if you educate yourself. Like read books, like go to these kind of meetings. What you're doing here is amazing. And then learn about it through all the different means that you can, like ADA is a like a nonprofit organization. They have some great, like pretty affordable, like if you join them, it's like $50 a year. And then they have like some free intro, like groups and things that I've seen that look pretty good. So I think learning what you need, it's knowing when you have a problem, trying to figure out, is this ADD related or not? Because it could be related to ADHD, but actually be depression. You know what I mean? Like, or it could be anxiety because you have ADHD. And so that gets kind of complex, but figuring out the skill and trying to practice things that help you feel less crazy and more, but I mean, for example, if you were, I mean, there are a lot of obvious things, but if you were struggling with executive function, say clutter is a really big problem, or making meal planning and eating is a real problem for you, understanding how ADHD impacts that is going to really, really help that. It may not help you change that, but if you understand it, you might get over the shame that happens. You know, like I can't eat healthy because I eat whatever I want as soon as I'm hungry, versus like knowing that I do that because my emotional regulation is off and I have a lot of trouble planning and having healthy meals in my refrigerator. So then, then you could work on, okay, there's the problem and what could we do? There are some really interesting coaching groups out there that are, I'm always trying to look into things that are more affordable for people. But my main thing is education. There are a ton of podcasts out there. There are a ton of good people and that are doing work that and offering free. I've heard people come to me now and they've been following a podcast or a TikTok that's ADD friendly. I would just make sure that it seems like accurate information, and that's like parsing that out is good, but one is hard, and the way to do that might be looking at the places, what kind of reputation, where else those people has shown up. You know, if they show up on Attitude Magazine and they've written something, or an ADA, they're probably they've sort of been vetted. So that's, I mean, you know, I thought I knew a lot about ADHD when I was re-diagnosed, and it still took me I mean, I still feel like I'm accepting parts of it myself. So like, I've been at this years and I still, you know, I still struggle with shame and anxiety related to ADHD. But I feel like, you know, it's been a process, and it's really about accepting yourself as you are. Some people I've said, and I've run groups for women, and, you know, the kind of let your freak flag wave high has resonated with some people. You know, just be who yourself and know that out of the box thinking is great. And it's going to make you, I mean, we are not part of the herd, and our brain and our nervous systems are really we need to be part of the herd to be part of the group. And so to know that you're out of the box, it doesn't mean you're not a part of the humanity, but to know that you're going to be that different. And the more you find friends that don't seem to don't want you to change, don't seem to need to have you change, you know, having people around that love you and support you will help you love and support yourself. I find that's really ironic. The more I felt like I loved and supported myself, the more I realized that a lot of my friends were not neurotypical. Anyway, so that's my brief answer. Thank you.
Thank
Jen,
you.
I think you also asked a question about living with other people with ADHD, and whether or not you live with people that have ADHD or you don't, or you live by yourself. Like, those are all different scenarios, and those individuals make it all different too, right? And so the different groups that Mary Rawson just talked about, especially like the CHADD groups, I know that ADA has like partners of ADHD coaches are really good at helping you deal with the specific nuances of any people that, you know, relationships that you're living with. Makes a big difference. We have a clarification on a question from Melanie, Dr. Heithaus. So with ADHD and depression, taking a stimulant, what kinds of antidepressants work well with stimulants?
Oh, I see. There is compatibility in general. I have treated a number of my patients for depression as well. The SSRIs are one group. There is a suggestion that the norepinephrine reuptake inhibitors might be better choices for people with ADHD. So venlafaxine, Effexor, desvenlafaxine, Pristiq, in that group. Another group is the dopaminergic antidepressants like Wellbutrin, bupropion, is one that I would consider. So the question is, of those groups of antidepressants, I would tend to veer toward or steer towards the dopaminergic and norepinephrine reuptake inhibitors. However, there are times when I will also prescribe an SSRI. So I don't know if that's answering your question, but you know,
Melanie, are you still on?
If I have a woman who is going through perimenopause, menopause, and has hot flashes, and is needing medication for depressive symptoms, I will be looking at, for example, Effexor or venlafaxine, which has an anti-hot flash effect. So,
Yeah,
there's
I'm actually still on, yeah, and I actually, so the stimulants really help kind of like with the mood boost and sort of the general like productivity of my day. I get up, I'm more action oriented with the stimulants, but I notice like, you know, I do have some traumatic memories and ruminations where it's just like it replays like negative thoughts over and over and over in my head. And so it's like not quite OCD, not quite depression, but like stimulants will help with it, but like it's still there, like sort of this like kind of sadness or whatever, but also the negative thoughts just over and
yes.
over. And I've tried like a lot of different ones. I've tried Wellbutrin and that kind of like was too much with my stimulants. And then I'm on like Luvox, which I think like I don't know if that's really helping, you know, so I'm just kind of confused as to where to go with my antidepressant.
Yeah. So, I hope you have a good provider who can kind of go through the different choices and options. And if you have a good relationship with your provider, sometimes you just have to trial a number of them before you find one that seems to be most effective.
They're just not as like they don't have the expertise that you have, you know. I've just noticed. Is there like 2 or 3 you might recommend for ruminating thoughts for antidepressants?
Well, have you ever been on an SSRI like Lexapro or
A long time ago, but I'm willing to try it again.
so maybe escitalopram
Okay.
or citalopram, Celexa?
Okay, yeah. Thank you so much.
My pleasure.
Let's ask one more question and then let's we've got some questions for Mary Rawson. Giuliano, I see you're still here. Did you want to ask your question or let me just get back up to it. While being at the fine-tuning stage.
Yeah, you can go ahead, please.
Yeah, go ahead.
No, you can go ahead. Your voice is better than mine. Thank you.
Well, being at the fine-tuning stage, how do you know what your baseline? For context, my psychiatrist and I tried Adderall first, side effects were bad. Then we tried Dexedrine and also didn't go so great. So the question is more about the in-between a tryout and the other. Giuliano, jump in if doctor has any questions.
Sure.
Yeah. Are you saying, you know, when is it time to move on to a different type of stimulant? Is that the question? You've tried Adderall, Dexedrine. There are a number of choices in the amphetamine family, like the tribeaded and mixed amphetamine salts. Another name for that is Mideas. There are liquid formulations of amphetamine. I think going over the list and kind of probably starting low and titrating up is the best way. And looking at the different, there are minute differences in the formulations of the amphetamines, for example. Some of them are dextroamphetamine sulfate, some don't have the salt. I mean, and people can really respond differently to those nuances, especially if they're very sensitive and they're very slow metabolizers. Then I will propose a number of different options. Not all prescribers do that. But I don't throw out the towel quickly. I give people a lot of different options and try to work with them by tweaking the dosages or the formulation. And as you saw those charts, I mean, there are quite a number of choices that we have. And but then it's also working, you know, to see if your insurance company will cover that. But with step therapy, like if you trial a number of them, then you can move towards the branded ones that might be best or better. But it's working with a provider who's willing to do like step therapy. So I don't know if that answers the question, but
no, it does. It's amazing. Thank you so
okay,
much.
so
And
I'm
also
thinking
the follow-up will be like between formulation and the other, like Do you recommend a certain period of time for tryout or like
Oh, they're very quick. The trials are-
recycle?
Right, and see, and that's the beauty of these medications. It's a very quick, at least I do a very quick step therapy. Other providers may not. I'll know, the patient knows within a few days. I don't have to trial something for weeks. We're gonna know within a few days, or at least within 4 to 5 days. So there are differences whether the medication has D and L. Dextroamphetamine, for example, there are medications with only dextroamphetamine. There are there are combinations of, the different types of amphetamine that's present in these medications. Dynavol is another example of D and L amphetamine sulfate that comes in a liquid formulation. So, actually, yeah. So, as an extended release. So, I don't know, I hope I've made some sense, but
No, you did.
there are a lot of nuances between, it's not just amphetamine. There are isomers of amphetamine, and how they're put together and what proportion can really matter.
Yeah, that's amazing. Thank you so much.
All right, so I want to turn it over to Mary Rawson, and I put a link in the chat for Dr. Heithaus's and Dr. Foreman's and Don Baker's conference on June 15th in Medina. There's a link in there, and then I want to turn it over to Mary Rawson and for any questions, and also Gretchen. Yep, Gretchen, you're still here, and anybody else that has any questions for her.
All right, I'm ready to answer.
I didn't have a question. I was just making sure that Mary was going to have some time pretty soon.
Oh,
because I wasn't sure how long it was going tonight.
thanks,
Oh.
Gretchen.
We could go forever.
Well, not so sure. But I'm happy to answer another question or so.
Oh, Eric has raised his hand. Go ahead, Eric.
I don't know if this is changing the topic too much, but that one I sent in about again, as a
Yes,
former
that's perfect for Mary Rawson, I think.
as former teacher, I was 35 years special ed teacher in the public school system, and now 15 years with CHADD I was a certified teacher with the parent-to-parent education program.
Mm-hmm.
The one question I got over and over again was people would, at the school and at PTAs, the special ed PTAs, they'd be diagnosed attention deficit disorder. They'd go to the school meeting and be denied services. So my focus at CHADD conferences was always the special ed law and that aspect of the parent classes. What I found out was the American with Disabilities Act has activities of daily living. I think it's called major activities of life, major life activities. You need to be impaired in something to be eligible for school classes, accommodations, services by the American for Disabilities Act for a 504 plan, or even under that, you can get special classes. I wonder, Mary, if you encounter people that have a diagnosis that although they're diagnosed attention deficit disorder, they're denied school-age services where you have to supplement them with other tests, like there's diagnostic tools for attention executive functioning. There's a test called the CEFI, the Comprehensive Executive Functioning Inventory, with standardized scores, and that could be represented. I wonder if you get involved or encounter a number of people that are confused. They got a medical diagnosis, but they can't get the education, and they're all confused. I don't know if I was too wordy.
Yeah, no, it totally makes sense, except that I only treat adults. So I don't see children, but I am a mother, and I have a child that has ADHD, and I can tell you that I was lucky that my school district did
Wow.
give an executive function test because I had a medical diagnosis from my child. And so that was, my experience was pretty smooth that my child.
That came into play where you had that extra
Right, but I
component.
would have fought for and I see adults that need accommodations in workplace. So I'm usually dealing with the that end of what accommodations can you get in work, and how, then I test and I give the diagnosis and I write a report. And then, my reports are taken by the University of Washington and other companies. So, and then I usually give a report and I write it to whom it may concern. And that way my clients can turn over to their HR department. So they have a written diagnosis from a psychologist. Usually that's enough. And then they get, but then we talk about what that means for them. And when they want to, I learned very quickly that some people are pretty impulsive. So one time I diagnosed somebody with ADHD, or I said something like, I am pretty much positive, and we've done some testing and it looks like you have ADHD. And then they went to their job and told everybody at their job that they had ADHD that afternoon. And I learned to preface any diagnosis with let's hold off on you telling everybody at work, because
do
that's
you
not
have
always
any
a good
do you
thing.
have any preferred diagnostic exams or tools that you rely on more than others that you might name, or no?
Yeah, I use the Brown scales, which is looks more at executive function difficulties versus the Connor. I don't really like I don't know. It's just not I've never used it, and I've always used the Brown. So I can't say that I've experimented. I like the Brown. It seems to match up with people's deficits. And so usually it's a pretty good indicator. And I almost always have a correlation, a response. Like I get a friend or family member or partner to give me a collateral contact report. And I don't always see those people in my office at the time of testing. Sometimes later I will, but I do try to get that collateral response is really important, I find.
I'm very appreciative of that of Dr. Rawson. Thank you.
Yeah, you're welcome.
Akili, am I saying it right? I missed your question earlier.
Yes, I was just trying to figure out some medication recommendations for emotional dysregulation.
Well, the stimulants do help in general. In kids who are especially hyperactive, well, I guess, in adults you see that mainly, you see more of the emotional dysregulation. In kids, I know that the alpha agonists like guanfacine and clonidine can be used to help with that hyperkinetics, if they're more hyperkinetic than inattentive. Again, in adults, it translates more into an emotional dysregulation. So I would be looking at the alpha agonists, again, guanfacine or clonidine, but they have not been approved by the FDA for use in adults. So when I've prescribed it in the past to my adult patients where I think it could be beneficial, the insurance company has denied it because they said it's not approved. But in general, the stimulants can be helpful for that. It depends on how, how severe that is, but an emotional dysregulation is a big one because it's not even included on the DSM-5, which is the Diagnostic Psychiatric Manual, the latest edition, 2012 or something like that. It's not even one of the criteria, and a lot of the experts in the field, we believe that it should be included because it's definitely part of ADHD. And when people don't realize that, people can be labeled as having an anger management problem and sent to anger management retraining or something. When they actually, there's another issue going on that needs to be addressed. So
I've had good luck with guanfacine. It has been one of those transformative things, but it doesn't work for everybody. And like Dr. Heithaus says, it's not always approved by your insurance company. My last fight, my second to last fight with the insurance company was after 5 years of taking guanfacine. They denied it, but then they finally approved it in a single pill instead of 3 individual pills. So instead of 3 1 milligram pills, they approved a 3 milligram pill. Didn't think to ask for that, but there's just no way to tell what they're gonna toss at you.
actually, one of my patients has hypertension, high blood pressure. So I switched the diagnosis code to hypertension, and they denied it, saying it wasn't one of the preferred medications for blood pressure management, which is true. But I was trying to find a loophole.
Thank you.
Yeah. Have you, Kaylee, I mean, Dr. Heithaus is not wrong. The insurance companies are rigid, with this. Have you looked at any of Dr. Dodson's, Attitude magazine?
No, I haven't.
Check that out. I mean, part of it is if you get enough information, it helps you be armed for dealing with the insurance companies, but it's not a sure thing.
But I as Dr. Foreman mentioned, it's the psychoeducation and the awareness. That's really great that you bring this up, because it's a very important topic, and one that we don't usually talk about when managing ADHD. Especially in adults, because we're not jumping all over the tables and chairs. So I'm really glad you bring this very important topic up. So thank you. Emotional dysregulation.
Thank you so much.
Okay. Any more? Oh, Kelly, go ahead.
Thanks. Not medication, but I am the mom of a 20-year-old son who was diagnosed ADHD and kind of refused to be treated. He was really anti-medication. By the time he was diagnosed, it wasn't something I felt, I needed to give him that autonomy. And now he's in that weird space of between a kid and an adult, where medically he's considered an adult. And I'm really trying to figure out, like, he's just really kind of suffering, didn't go to college, has what Dr. Rawson was saying really resonated with me. I think he has a lot of shame, and he doesn't realize how smart he is in the areas that he does excel in. So I wonder if you have any advice about just leading him to resources. I just went over to ADD.org and I saw there's a young person's group, and I think he's at a point where I can get him to maybe go to something like that. But I wonder if you guys have any advice on that.
Well, I think it's a really hard thing, because it's really painful to watch, especially your child, shoot themselves in the foot when there are resources out there and people who, help they could get and education they can get. But the truth is that I think the best thing you can do is love and support your child, even though they may be making a lot of mistakes, and lead with that, because they have to be ready to get the change, and you can model by going to therapy, learning things maybe about ADHD yourself, like you're doing right now, which is awesome. But the autonomy is really important. I mean, I don't think I don't want to confuse. What I'm saying is not that you shouldn't have any boundaries, right? If the person is saying, you know, doing things that you should have appropriate limits with, but these would be limits that you would have with anybody in your world. So not letting them off the hook for behavior that's immature, or, you know, but then trying to be sympathetic. And it's just such a fine line to walk. And you know, I think that you'll have windows opportunities. One organization that I will mention is Impact Parents, and that is a couple of coaches, and they do work, you know, mostly virtually, but they happen to be in the Atlanta, Georgia area. But there are two women. They both have multiple children with ADHD, and even though that's their personal story, they work with a lot of other coaches, and then they work with a lot of other people. And I think their children are now all in their 20s. So now they have groups for young adults, and they mainly they coach parents. And I've participated in some of that coaching, and I think that they have a pretty good, like, what I would consider like head on their shoulders about respecting kids, and then also understanding having a disability perspective. So that might be something you look into, because sometimes it's just, I know that you want to pull out your hair, and I appreciate that. And I also appreciate that on the other end, just like there's civil liberties, you know, giving your child autonomy to make mistakes. It is part of just learning for themselves. So it's a fine balance, though.
Thanks.
I want to mention medications real quick. So again, medications could be quite helpful. But I think what's important is that a young adult work with the right provider who could go over the benefits, side effects, and work closely with a young adult. So there's, you know, finding that right provider could be very tricky. But maybe finding someone that your son could, you know, resonates with and becomes informed about that, you know, medications as being an option, that could potentially make a huge impact.
Yeah, thanks. I think you're right about that too. Appreciate it.
Okay, Emily?
Hi, this is a question for Mary Rawson. I'm actually seeing someone right now who uses Sims, and it's actually been really helpful for emotional regulation. But I was seeing her for like trauma-related stuff, and I've been seeing therapists on and off for like 15 years, and it was just last summer when I realized probably a lot of my remaining emotional dysregulation is probably related to ADHD. And so I was wondering, in your work with using Sims, how do you see it addressing ADHD?
Well, thanks for the question. So I'll just describe what Sims is really briefly. It's kind of the founders have written a book that was published, I guess, 2 years ago, Complex Integration of Multiple Brain System. And it's a paradigm of psychotherapy that uses neuroscience-based understanding. They have this belief in different brain systems, that all brain systems are adaptive in certain ways, even brain systems that we think of it more negatively, like shame or fear, grief, guilt. All of those can be adaptive, because sometimes grief and guilt, like guilt at the other spectrum of guilt is belonging. And so like you will learn that you're going to be the outside of a group if you do things that make you feel guilty, and so you'll stop doing them. So even a psychopath would stop doing certain behaviors because it's going to lead to them getting, I'm going on and off, but anyway, you get the idea. So the question about Sims, and one of the things in Sims is that you're helping somebody, you're inviting them into a meditation, and then you are directing through this, what we call it, initial directed activation of these brain systems. And I tell people that when we start, we're gonna, I'm gonna say things that are completely positive to you. There's not gonna be any emotional abuse or anything hard that I'm gonna say. It's kind of the opposite. In some ways, it's the opposite of exposure therapy. But because it is completely positive, like we're here paying undivided attention, unconditional caring attention to you, that is actually very triggering to a lot of people who have a lot of trouble staying connected with a positive person and in an intimate setting, which when I say intimate setting, I just mean that I'm sitting 3 feet away from them. I'm not touching them, but I'm looking directly at them and my eye gaze is consistent as much as possible. The way it works for ADHD, and what I noticed, because I'm the kind of therapist that tries pretty much everything that I put into practice. And so when I've had my own therapy, it's that one of the things is that it's a lot of focused attention, which can lead to expectations, but there's a lot of coaching in the therapy to help people regulate themselves. But one of the things during this process is you're constantly being asked to come back to your somatic sense, peripheral nervous system, or the entire body, right? We're coming back to the body. And that guidance of attention building is really powerful. It's the same that people do in mindfulness training, that when you learn to direct your attention and you learn to bring your attention back, but it's more powerful because you've got somebody looking at you, telling you to do that. It's a little bit, so that's kind of the brief answer. I really love Sims, and it took me a long time, and I still feel like I'm a novice, although I've been honored I'm going to start training other providers doing Sims next year. So I'm honored to be asked by one of the founders to do that. So I've been doing something right, but I still feel like a novice. It's kind of a difficult therapy to do, but it brings me into a really close connections with people, and I see profound changes. And a lot of people saying they've never had experience like that, with anyone else. And it can be really helpful, and it can be really slow going, just like any therapy can be. So I'm going to talk about that at the conference. I'm going to talk about neuroscience-informed psychotherapy and why that's particularly important for ADHD, because, we have all brain problems, all mental illness, I wouldn't say necessarily starts in the brain. It could start in the gut, but it affects our brain. It affects our neurobiology. But with a neurobiological difference like ADHD, using neuroscience to help treat it makes sense. That's one of the reasons I've always been really interested in neuroscience and neuroscience-informed psychotherapy. So
that's so cool. We have one more question, and then I think we should probably call it. 2 more questions. One's a quick one. So somebody asked, how does therapy help? How can therapy help with self-criticism and shame for one's ADHD traits? Does it depend on the therapy modality, or is Sims specifically good for that? Or how do you decide if you're going to help somebody with their self-criticism and shame for the ADHD traits? How do you work with that with their therapy?
Well, it's not as so the question is, how do I decide what ADHD traits to treat, or whether I would use everything? Is that the question? Can you ask it again?
How do you help somebody with their guilt and shame over their ADHD traits?
Like versus ADHD traits, or where,
I think it's the self-criticism and shame because of I'm picking on myself. I'm criticizing myself because of my ADHD traits. I'm so frustrated. I'm so scattered. I'm always late all the time. why did you do, you know, it's like that negative self-talk. And then
Like,
uh,
are you
I
saying
think
people,
I'm extrapolating from
right?
what the question is saying, but I believe that it's for that negative self-talk and shame about one's
Behaviors.
ADHD behavior.
Yeah. Well, well, like this is sometimes people come to me and say they want to coach and they want to change their like ADHD behaviors. And I explain that the way I understand this is that, I mean, it's not that I don't talk to people about behaviors and I don't give tips and strategies and I don't do sims through this intensive mindful somatic practice the entire session. However, I feel like that experiential doing the complex integration of multiple brain systems kind of work is getting at the root problem, right? Which is shame. Because say, you know, you may continue, like I have continued to have time management problems. And yeah, I use strategies like alarms and other things that help me. And I actually probably use those more because I just accept that I have a brain, you know, I have time blindness and I have a brain difference that makes it more difficult for me. Right. And I accept that. And part of accepting that was learning that I deserve to be loved no matter what. And I deserve to care for myself and I deserve to connect with myself. And that it is important for me to show my clients respect. So I try to be as timely as I possibly can. And I explain and I do all these other things, but loving myself and know that I matter and that if I'm so stressed out getting to somebody on time that I like, I mean, this is an exaggeration, but having a panic attack because I'm and not giving myself grace when I'm 3 or 4 minutes late, then that is an issue of sort of perfectionism getting in the way of just my time blindness. So that's not maybe the best example, but the idea is that I talk about getting to the kind of the root of the problem, which is you matter, you deserve to treat yourself well. And when you are caring about yourself and not feeling overcome with guilt and grief around your symptoms of ADHD, then you might be able to approach them better in a more direct way and actually have curiosity and experiment with things. Because when we have so much shame, we're not willing to look at it. Sometimes we can't look at something very clearly because we're so afraid to connect with that part of ourselves. So it's a deeper way to look at it. And if you can change that deeper way, then some things come more easily. I can't hear you.
I just said some of the things I say to myself, I would never say to anybody else.
Yeah. And I think that listening to our voice, you know, and trying to change those voices is it's really hard and it's really, really powerful. And one of the things about this therapy is we're saying these positive assertions like you matter, you know, you're really important, you're the most important person to us right now. You know, you deserve caring attention and hearing that and then taking that away and practicing it. That's what I recommend between sessions really starts to help people. From a psychoanalytic perspective, it would be interjecting a part of themselves that is more caring, right? But who knows what is actually happening? I mean, we know what's happening in the brains to some extent, but who knows which theory is more powerful? But the whole idea is that you are creating a different aspect of self that's kinder.
That's very cool. Well, I think we should give everybody time off for good behavior. We've gone over 25 minutes, so thank you everyone for hanging in there and for all the great questions. This has been awesome. I love this one. Truly appreciate it. Any final comments? I put the conference in the chat. Any other questions? If you have any questions, just email Seattle at CHADD.com or no, sorry, CHADD.org. And I will route the questions in the right direction.
Should say, Beth, if it's another great meeting. If anybody's here and not a member, you didn't encourage them to be members tonight, I'd encourage you with them. www.chadd.org and stuff on the membership tab. Support us at the chapters. I love coming to your meeting. I run the Southeast Florida CHADD chapter meeting. We do have a regular schedule. It's East Coast time, 1 o'clock our time, 10 a.m. the third Tuesday of the month. If some of you are looking to talk further, you find me on it with information and kind of support fielding questions, kind of modeling after Beth. And everybody do well on your journeys. And Angela and Mary, thank you for tonight. It was top notch. Beth.
Eric, thank you so much. And thank you for being here at midnight your time.
Okay.
Wow.
Love it. Yeah.
Yeah, thank you, Beth, for all the work that you do. It's truly needed, and all of us, just a big heart of thank you for this incredible work that you're doing. And thank you for inviting Dr. Foreman and myself.
Yeah,
And
thank you so
we
much.
are always open to coming back.
Yeah, I love it. I appreciate
I've
it.
heard those great things about you, Beth, from Don and Angela, so it's great to meet you. Thank you for having me.
Thank you so much. I'm looking forward to hearing more. So everyone, thank you tonight. It's going to be about probably sometime within the next week. Once I get the recording to Evan will get it posted, and then it'll be available for everyone. So I appreciate everybody's time.
Thank you.
Thank you. Good night.
Bye.